This conference will now be recorded.
Well, since I hope everyone is here and we have a lot to cover, we really should begin today's virtual conference. I really appreciate you all for attending today's virtual conference. A very good morning, good afternoon, or good evening to one and all present here virtually with me today. Let me introduce myself. My name is Clara Beckbroom, Conference Secretary at Coalesce Research Group LLC, and I will be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. Finally, I would like all thank all the attendees of today's participants of today's day two virtual conference on clinical dentistry and oral health, and I hope you enjoy the webinar and gain the knowledge from the sessions today. We all hope your participation will contribute to new research findings and that will lead to new collaborations and research initiatives. Before we start with the session, I guess some of you will be new to GoToMeetings app. Let me just explain you the important tools required for the participation. On the GoToMeetings app or a web page, you can find four icons at the bottom center: mic, camera, screen, and button. The mic button, click on that to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it does not cause any disturbance to them. Camera button, you can use this button to share or unshare the web camera. If you have the option to share the web camera, you can do it and it's completely your choice. Screen button, you can use this button to share your screen. This is the main part. During your presentation, after I call your name, from my side, I will be making you as a presenter and will give you the permission to share the screen. Then only you can able to share your screen. If you are a Mac user, kindly accept your invitation to share the screen and go to your settings and select give the permission for GoToMeetings to share the screen. Then you need to leave the session and rejoin the session again. So once I make you as a presenter, you can click on the screen button and you will find a pop-up window to share your screen. The end button, this is your fourth icon where you can use this to leave the session. On the top right corner, you can use this option to change your display settings. At the top right corner, you will have three icons: people, chat, and settings. In the chat option, you can chat with me or you can chat with any other participants on your requirement. For the settings, you can use this button to check for the settings of your speakers and microphone. As I mentioned earlier, kindly remain muted during the presentation so that the presenters does not get disturbed. And for any questions, you can ask the questions on you can send your questions in the message box too. Well, let's not take much of your time. Finally, I would like to thank uh, all attendees of today's conference. I would like to request you all to please give a brief introduction about yourself before starting with the session so we can know about you virtually. And now let's move on to our session. The first presenter is Dr. Shrikant Kumar Malineni from Al Habib Hospital, Saudi Arabia. Hello, Dr. Shrikant. Are you ready with your presentation?
Yes, ma'am.
Good morning. Now I am making you as a presenter. Kindly click on the screen button to share your screen, please. Yeah, your screen is shared. You can make it as a full screen mode and start your presentation.
Yeah. Good morning, everyone. This is Dr. Shrikant Malineni, presently working as a pediatric dentist in Dr. Sulaiman Habib Hospital. First of all, thank you very much for inviting me to present a topic in this virtual conference. My title for today's presentation is Prevalence, Occurrence, and Characteristics of Supernumerary Teeth among the Arabian population. This is one of our interns project. We all know that we have 20 primary teeth and 32 permanent teeth. If we have anything extra, we call it as supernumerary. If you can see in the the slide, something is extra, which is not normal. Anything is extra than the normal complement, we call it as a supernumerary. Likewise, if something is extra than the teeth, we call it as supernumerary teeth. There are a lot of definitions which I'm going to go through on supernumerary teeth. Teeth in excess of the unusual, usual configuration, which are 20 deciduous and 32 permanent teeth, considered as supernumerary teeth. Some of the authors suggested teeth excess to the normal complement, and one or more additional teeth or to the normal series are called supernumerary teeth. So there's a classic definition given by my mentor. Any tooth or odontogenic structure that is formed from a two germ access to the usual number in any given region of the dental arch. It gives explanation for everything. If you say odontome, if you say more than two or three supernumerary teeth, and then any odontogenic tooth structure. So this definition has been popular now for the supernumerary teeth. Coming to the prevalence, there are a lot of studies in the literature published, around the globe. There are a couple of studies presented with no prevalence of supernumerary teeth. Some of them presented like high prevalence, especially from Mongoloids and southern Chinese. Coming to the gender predilection, all the studies, let's say majority of the studies, reported that supernumeraries are more common in males than females. Coming to the epidemiological part, most commonly seen in permanent dentition. There are a lot of theories for this, but I'm not going to get into that. And the occurrence will be commonly seen in anterior part of the maxilla, which is premaxillary region. When you compare with the mandible, maxillary arch has 8 to 10 times more frequent. There are a lot of theories which actually says how the supernumerary forms. The first and oldest theory is atavism, which says it is reversion of our ancestral characteristics. People say there are a lot of teeth with our great grandfathers. That's appearing now. And sorry, dichotomy theory. So this theory says one tooth bird divided into two equal parts. One could be the normal complement, other one is supernumerary. There is one more theory, the local trauma actually reason for the formation of extra teeth. There's one more theory coming up after that, which says hyperactivity of dental lamina will cause the formation of supernumerary teeth. And eventually, no, not all these characteristics or theories are not going to form the supernumerary. The genetical thing is going to form. Hereditary is the one reason for the formation of supernumerary. Anyhow, a lot of theories, but still there is no exact etiological factor for the formation of the supernumerary teeth has been established. And Prof. Brooks says environmental and genetical factors are equally play a role in the formation of supernumerary teeth. Coming to the occurrence, majority of the cases you see single, or in some cases you see multiple, unilateral and bilateral occurrence in both jaws, especially in case of supplemental premolars. Majority of the times you see bilateral occurrence. Multiple supernumerary teeth, sometimes they present more than five. We do consider as a multiple supernumerary teeth. What is the occurrence? There are different theories for the occurrence as well. Deviations in the premaxillary region actually forms the supernumerary teeth. Deviation may lead to the formation of supernumerary teeth. The other anomalies, including even invaginator's teeth. So coming to the multiple supernumerary teeth again, it has high incidence in males, commonly seen in canine premolar regions. Occurrence of supernumerary teeth in the same as there is no difference between maxillary and mandibular arches. Recently, these two papers, when I was searching for the multiple supernumerary teeth, actually paid my attention. There was 232 teeth from a boy's mouth, which was also an Indian boy. Subsequently, there was one more paper which was published in the Guardian. 526 teeth are denticles, what I would say, they consider as a supernumerary teeth. So just I want to show you that there's the possibility of formation of such a number of teeth. And then these supernumerary teeth are associated with many conditions and many syndromes. Most common conditions where you see the supernumerary teeth are cleft lip palate, cleidocranial dysostosis, and Gardner's syndrome. Less common are a couple of syndromes where commonly you see in Ehlers-Danlos syndrome and Noonan syndrome. Coming to the classification, if you look in on Google Mother, you could find a lot of classifications like based on location, based on morphology, like based on orientation. Myself and Prof. Nool actually we sat together and we combined all the classifications which are available in the literature, and then we have classified the supernumerary teeth based on four categories: location, mesodents, premolar, paramolars, distomolars, parapremolars, morphology, conical, tuberculate, and supplemental odontomes. Orientation, it could be vertical, inverted, or horizontal. Position, buccal, palatal, and transverse. Coming to the complications, these supernumerary teeth are there are a lot of complications which has been caused by the supernumerary teeth, which could be from simple midline diastema to cystic formation. We'll go through one by one complications. You can see crowding, the supplemental lateral incisor causing severe crowding in the maxillary arch. Delayed eruption because of supernumerary tooth 2-1 has been delayed in eruption when you compare with the contralateral one. Coming to the rotation, supernumerary teeth even do causes rotations and displacements of permanent teeth. Root resorption. Supernumerary teeth might cause the root resorption of adjacent teeth, especially when they're associated in the premaxillary region. Complications, as I told you, the simple diastema to cystic formation. Again, this paper is also from my mentor Antanappa. So now we have gone through all those complications. And then how to identify these supernumerities? This is one of my papers published in EAPD, sorry. And the localization is very important to identify the supernumerary teeth along with the clinical examination. Radiographs are very much important. Identifying supernumerary teeth is one thing, and then very important thing is to localize the supernumerary. So any combination of the radiographs can be used for the localization of supernumerary, which is very important when you do surgical intervention and the proper treatment planning. So our study says vertical tube shift technique is the best thing compared with the horizontal tube shift. Coming to the prevalence, basically, I did my bachelor's from India. These are the lot of studies were there, published from different parts of India. This is one of our study, published from Narayana Dental College. 0.21%, which is around more than 4,000 kids we actually checked clinically and radiographically. This is where I studied from, Devis 2.7%, and then there are two more studies by Prof. King, which is around 2 to 2.4%. Then where I'm staying now, this is one of the old study which has followed very good methodology. They found 0.5% in Saudi Arabian population. I just gone through the literature before the presentation. There are two papers which consider as very good papers when those people who are working on dental abnormalities. These two papers suggest the prevalence of supernumerary teeth based on panoramic revisited. All the studies which were taken panoramic radiographs into consideration for their prevalence figures, they did published in Pediatric Dentistry. The author says the prevalence of supernumerary teeth is higher than what they actually presented in the literature. It could be from 2.4 to 6% or even more. The same authors actually published a systematic review and meta-analysis to find out what are the common diagnostic tools used to predict the prevalence of supernumerary teeth. So majority of the times they use a couple of the authors use dental casts, couple of them use clinical pictures, couple of them use radiographs. So moving on to the present topic today, I just gone through the literature. There are a lot of studies which been focused on dental abnormalities. These are the studies from our Saudi Arabia, which are reported on the prevalence of supernumerary teeth. So it stands like 0.4% to 15.6%. Coming to the aim of our study today was to determine prevalence, occurrence, and characteristics of supernumerary teeth in Saudi Arabian population. So we got approval from University of Majma before to the study, and we look into radiographs retrospectively from January 2018 to December 2020. Only healthy patients with clear radiographic records were included in the study. The patients with syndromes, cleft lip palate, unclear radiographs were completely excluded. And also, we considered the first visit or no history of extraction, or also, very importantly, considered for the selection of the subjects in our study. The panoramic radiographs taken, all the radiographs taken from the same equipment, and the assessment includes the patient's age, gender, type of supernumerary, occurrence of supernumerary, orientation, morphology, and position. Only single examiner involved in data collection and analysis. Coming to the results, we found 2%. Among this, based on our inclusion and exclusion criteria, we found only 1904 panoramic radiographs which were included in the study. We gone through all those radiographs, we found 2% patients had 46 supernumerary teeth. 79% were males, which has been already in the on par agreement with the literature. Majority of the studies says males were commonly affected by this numerical anomaly. The mean age of our study was 16.27 years. Type of supernumerary. So, as literature says, 90 to 98% of the supernumerary occur in premaxillary region. Likewise, in our study also, we found 87.2% supernumeraries in the premaxillary region, 4.3% distal molars, and 8.5% supplemental premolars. Coming to the occurrence, we have 23% bilateral occurrence and 77% unilateral occurrence. And coming to the orientation, majority of the supernumerary teeth are inverted, which is around 70%, followed by normal and transverse. Coming to the morphology, 60% of the supernumerary teeth are conical, rest of them are tuberculate. We didn't find any odontomes in our study. Coming to the position, 34% of the supernumerary teeth are already erupted and 66% are impacted in our study population. Coming to the strengths and limitations of our study, this is the only study discussed about characteristics from Saudi Arabia, one of the studies with a large sample size. Coming to the limitations, it is a hospital based study. Location of the supernumerary, which is buccal or lingual or within the arch, was not considered for the evaluation. Moreover, we couldn't find. So before also we didn't actually look into this objective in our study. Sample was specifically from one region, so you cannot generalize these results. Comparisons with the gender or occurrence or characteristics was not being done. Coming to the conclusions, the prevalence of supernumerary teeth in Arabian population based on our study population within the limits was 2%. Unilateral occurrence was more than bilateral occurrence, which was 77%. Mesodents are very common, which is about 87%. Impacted supernumeraries are very common compared to the erupted ones. And inverted type compared to the normal orientation transverse, conical shape are very common. Thank you very much for giving me such a nice opportunity to present this one of our intern study. And I also thank my team who helped me in in presentation and also data collection. Thank you very much.
Thank you, Dr. Shrikant, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Doctor, for your presence and presentation. Now let's move on to the next presentation from Dr. Herda Gaffer Hassan Hamad from Menofia University, Egypt. Hello, Dr. Herda. Are you ready with your presentation?
Hello. Yes, dear, I am ready with the presentation, and I am
Okay, now
waiting
I'm
for
making you as a now I'm making you as a presenter. Kindly click on the screen button to share your screen, please.
okay for a while.
I
For a
have made you
while.
as a presenter.
1 minute, please. Wait, just wait. I hope it's okay. Is it shared already?
Yeah, your screen is shared. You can start your presentation.
Okay, 1 minute, please.
Can you make it as a full screen mode and complete your presentation?
Again, for a while. For a while. 1 minute, please. Hello, everybody. Is it okay now? Shall I start?
Yeah,
Yeah.
it's
Hello.
okay.
Yeah. Hello,
Yeah, you can
everybody.
count your camera if you want to see your
Yeah,
camera is
I
up.
turned already the camera, yes, to recognize my colleagues and the professors. So also I
Yeah, but
hope you
we are unable to
can.
see your face. Your camera is showing the roof.
Shall I? Is it closed? Shall I close it?
No, it's you can open it. No problem. Your the camera is showing your roof.
Okay, no problem. Because there is, if you search on the Google, you will find many Huda Ahmed. That's
Okay,
why
fine. You
I'm
can
like,
start your
yeah,
presentation. Make it as a full screen and start your presentation, please.
yeah. For a while, please. Yeah. Hello, everybody, dear colleagues and professors. I am really proud to recognize you, and I hope we can share together the research work and the scientific activities and the scientific research, especially nowadays with the development and the innovation that is proving and progressing every day, and even every moment and every minute. I would like to present myself. I am Dr. Hoda, Assistant Professor in Dental Biomaterials, Faculty of Dentistry, Menofia University, Egypt. I worked before also in Badr University, Cairo, Egypt. I worked in Misr University for Science and Technology as well, Egypt. In UAE, I was Assistant Professor in Gulf Medical University, Ajman. As well as I worked in Batarji Medical College, Jeddah, Saudi Arabia. My topic today is dealing with an important issue which is interesting nowadays concerning the biomimetics. We need to be as much as we can simulating nature to be lesser biohazards, especially with the degradation of the biomaterials, which is might be not usually safe, as we said. That's why the novelty of our topic was how to innovate or try to make research for a material which is simulating the from natural products that is simulating the hydroxyapatite present in the enamel and dentine. So our topic is dealing with biomimetic human enamel remineralization using a calcium extract from nanofish bone and eggshell. That was an in vitro study. First of all, I would like to thank the conference and the team of the conference who invited me for this scientific event and presentation, and I hope it will be productive for all of us. My colleagues in the research to be having the teamwork and following the rules. I have Dr. Mona. She is associate professor at that time, and now she is full professor, operative of dentistry faculty, operative department, faculty of dentistry, Beni Suef University, Egypt, as well as Dr. Professor Amr Helmi Bolok, who is Professor of Oral Pathology, Faculty of Dentistry, Minya University, Egypt as well. The materials and methods. First of all, we have got the from the faculty of from University of Beni Suef, the ethical approval from the research center there, and the number was as well achieved in October 2022. The study design, the randomized study for the in vitro study has been conducted, and a calculation for the sample size with a precision of plus or minus 5, and a total of 34 freshly extracted human third molars were collected from the oral surgery clinic in the university. Designing the study, 30 out of the from the 34 freshly extracted teeth were divided into 3 equal groups, where each group is formed of 10. From the group 1 was considered as reference for the assessed normal quantitative content of calcium and phosphorus. The second group represented the was the group that was demineralized first for 96 hours. Then it has been investigated with energy dispersed X-ray spectroscopy. Then it has been soaked again in a freshly elaborated remineralized solution of fish bone or nanoparticle solution for about 7 days. The third group was demineralized again first, what we call the artificial demineralization, which is what we say the policy nowadays for the researchers to assess the effect of the remineralizing solution. They do first the stage for the demineralizing solution or by artificial demineralizing solution first to assess the effect of the recently innovated remineralizing solution using chicken eggshell for about 7 days. So the group 1 was reference, which is the normal. Group 2 was remineralized after the demineralization using the fish bone, while the third group was the eggshell remineralized after the demineralization with the artificial solution. And the study was now to assess the remineralizing effect of fish bone against the eggshell. The remaining out of the 34 teeth were 4 teeth from which were investigated for the scanning electron microscope. The scanning electron microscope, one tooth was done for a sound tooth. The second one was a tooth for assessment of the enamel after the demineralizing regime or solution that has been used in the study. The third group for the scanning electron microscope for the remineralized enamel surface with nanoparticle fish bone solution. And the fourth group was remineralized with the chicken eggshell nanoparticle solution as well. How the nano fishbone powder remineralizing solution has been prepared. First of all, the Nile tilapia fishbone has been extracted, brought, and had been separated from the organic materials, and then the fishbone were cleaned and dried to room temperature. Then they were calcined to 900 degrees centigrade for 5 hours in an electric furnace. Then the ground ashes of the fish bone were sieved to a powder size of 100 to 250 micrometer. And at the time we can note that the color of the particles was brown. And this we can note from the biomaterial science that the particle size of the material, whether it is micro size or nano size, it might affect the mechanical and physical properties as well as sometimes the biological effect, like for example the nano gold, as we know from many researches. So now the particle size that was micro size was brown. We noted that that color will be changed. Follow me please. The collected particles from a sterile container were sent to a company. They were refined to fine particles to the nanoscale. And at the time, for the nanoscale, the company was present in Egypt, as the reference A showed. And at that time, the particles were nano size, where the color, which is one of the physical properties, has been changed from white to white yellowish color. The energy dispersive spectroscopy investigations has been done for the particles, as well as the scanning electron microscope. Now we can see the edits done for the material to check the calcium content and the potassium and content and other minerals. Now we get the particles from the company in the nano size for the fish bone, where we weighed 1 gram for the nanocalcite fish bone particles, and we blended it with 33.3 milliliter of sterile deionized water. After the blending it in the sterile deionized water, we get the most superficial one, which is the clear fluid on the top of the collected A tube. The freshly prepared 3% fish bone remineralizing solution has been collected, and the scanning electron microscope was done for the particles. What about the nano chicken eggshell remineralizing solution preparation? It has been prepared by the collection and separation as well, sure, for the eggshell from the organic content of the eggs. Then it has been washed in distilled water, dried to room temperature, then soaked in boiling water for about 10 minutes. And after drying to room temperature again, those eggshell were ground in a sterile mortar and pestle. They were again calcined to 900 degrees centigrade for 1 hour in an electric furnace. Then they were sieved to fine powder in the micro size again, which was 100 to 250 micro size. Again, the collected powder in sterile container were sent to company to refine the particles, as we said, in biomaterial from top to bottom system to get the refined particles in the nanoscale. Then the investigations were done for the particles concerning the edX and the SEM. Then 1 gram of the nanocalcine powder were weighed and blended with 33.3 milliliter of deionized sterile water, where the clear fluid again on the top were collected, and at the time we get the freshly prepared remineralizing eggshell solution. This is the scanning electron microscope for the nanoparticles after the preparation. Then we went for the teeth preparation. The 34 selected teeth were cleaned carefully and examined for individually to exclude any abnormality, any cracks, any deficiency or abnormalities in the tooth. Then they were placed in artificial saliva, and they were stored in at 37 degrees centigrade in an incubator to simulate the oral cavity, as we know. In the middle third, then for the 30 teeth that entered in the 3 groups of the study, the middle third of the buccal surface, a square was drawn as a window. A square window was drawn about 3 by 3 millimeter in the middle of the buccal surface of the third molars, human third molars, and the rest of the teeth were double coated with nail varnish, and they were wrapped with tin foil after drying. The prepared specimen were stored separately in test tubes containing a freshly prepared artificial saliva. The artificial saliva has a pH of 6.57, and so the artificial saliva was freshly prepared in Faculty of Pharmacy, Alexandria, University, and they were used for 48 hours at 37 degrees centigrade in an incubator. This is the scanning electron microscope. This is the edX for the artificial natural tools. Demineralizing regime. The demineralizing regime was done, we know, for the group 2 and group 3 before the remineralization stage, and the group 2 and 3 T specimens were removed after the artificial salivation, and they are individually again immersed in test tubes containing freshly prepared demineralizing solution, and they were daily changed to prevent the saturation with the demineralizing solution. The pH of the demineralizing solution, as we know, acidic for damn sure, that was 4.2. The demineralizing solution was prepared in Al-Azhar University, again in Egypt as well, and it is kept at 37 degrees centigrade for 96 hours. So the demineralization regime was done with the artificial salivation, with the demineralizing solution with a pH 4.2 at 37 degrees centigrade and for 96 hours. Afterward, the specimens were removed, they were rinsed for 5 seconds, and they were placed in distilled water on top of the effect of the demineralizing solution, and they were stored again in artificial saliva to after stopping the effect of the demineralizing solution at 37 degrees centigrade in an incubator until subsequent study step. The remineralizing regime. Going to the remineralizing regime for the group 2 and 3, it will be different. So for the demineralizing regime, they were the same, while the remineralizing solution will be differentiating between group 2 and the group 3. The group 2 and 3 demineralizing specimens were stored in saliva individually, as we know, where they were removed, and again they are separately immersed in their respective freshly prepared enamel remineralizing solution. And here the remineralizing solution pH was 7 for the eggshell and for the fishbone remineralizing nanoparticle solution used in the study, and it is incubated at 37 degrees centigrade once a day. Afterward, those specimens were removed and they were rinsed for 5 seconds again and with distilled water, and they are incubated for the rest of the day in artificial saliva at 37 degrees centigrade. Remineralization regime of the specimens was daily repeated. It's not for only once as demineralization. No, it had been repeated for 7 successive days. And the 7 successive days will be following the reference in the methodology with the respective remineralizing solution according to the group. This is the scanning electron microscope. The first one for the fish bone and the second was for the eggshell remineralization of the enamel surface. Then we went to the assessment of the groups. We did the edX or assessment for the quantitative evaluation for the calcium and phosphorus content of the T specimens which were performed. Then scanning electron microscope examination was done was a scanning electron microscope after the edX was done for after the teeth has been washed in distilled water. They are gently dried, they are mounted with aluminium, and the enamel surface was quantitatively scanned with the electron microscope, scanning electron microscope topography with a magnification of 400 at 20 kV. Statistical analysis. Collected edX data throughout the study steps were tabulated to be statistically analyzed using SPSS 20 at a significant p-value less than or equal to 0.05. Paired sample t-test statistical analysis was used for the difference between calcium and phosphorus levels of the teeth within group 2 and 3 after remineralization of the demineralized enamel surface. An independent t-test was implemented to compare the remineralization potential of the fish bone versus the eggshell. The obtained study was done first for the pH. As we said, and we have explained in the methodology, that the pH is a very important and crucial issue to be considered in our study. For the starting from the normal salivation, the demineralizing solution, the remineralizing solution, whether fish bone or eggshell. So the pH of the freshly prepared enamel remineralization solution was daily rechecked, and the measured average value was 9.09 and 9.48 for the fish bone and the eggshell respectively, where we can note that relatively the eggshell is little bit higher than the fish bone. The mean calcium content in the fish bone and the eggshell was 12 and 50 respectively, where the calcium content was higher in the eggshell. Furthermore, the mean phosphorus content in the fish bone and the eggshell was 16.32% and 0.27 respectively, where the phosphorus content was higher in the fish bone much more than the eggshell. In remineralizing, in demineralized enamel, the calcium value was 0.33%, and that of the phosphorus was 2.16%. Again, concerning the results, paired t-test was used for the difference between the calcium and phosphorus level for the demineralization of the teeth enamel after demineralization regime used in the study within the groups. The calcium level is noted to be in the normal enamel about 40, while in the fish bone it was about 2. It was the calcium level was about 40. The mean calcium in the normal group 1. In group 2 it was 38, and in group 3 for the eggshell it was 42. Why it is here higher than the normal? We can say it might be due to the demineralization, because the demineralization of the natural tooth has been removed a lot of the calcium, and at the time it might be this difference due to the demineralization stage or demineralization regime or protocol that has been used before the remineralization protocol of the solution of the study. The phosphorus level was 17 in the normal natural group 1. For group 2, the fish bone, it was about 17.23, and for the eggshell, it was about 20, which is not a big difference, I think. The independent t-test for the remineralization efficacy between the fish bone versus the eggshell, we noted that the mean difference was 5.28 for both the calcium level as well as the phosphorus level, which is much more higher than the p-value or that we noted. Lastly, we collected all the data and we put it in a histogram to compare all, where the D here represents the demineralized calcium, where the demineralized calcium enamel surface the calcium was 1.67. The normal calcium in the normal enamel was about 40, as we have seen in the tables. For the fish bone remineralization, the calcium was 38.5, where the calcium for the eggshell was the highest of all, that was 43. Again, for the phosphorus for the demineralized enamel, it is 2.16. For the normal, it is 17.7. For the remineralized enamel surface with fish bone, the phosphorus level was 17.23, and for the eggshell, the phosphorus was 20. We can say that from the obtained results, we can suggest that the highest calcium level with the limitations of the study was for the eggshell nanoparticles for the calcium, and to a lesser extent for the fish bone, which has been also proved effect in the remineralization. So we can say that if the both fish bone and eggshell might have a remineralizing promising effect for the enamel surface, human enamel surface, and which is relatively might be higher in eggshell rather than the fish bone relatively, but both of them have shown a promising effect for the remineralization of the enamel surface. Conclusions: within limitations of this in vitro study, the following may be concluded: demineralizing regime seem acceptable and successful, and it is for evaluation of the remineralization potential of certain biomaterials. Nanotechnology might alter some biological, physical, mechanical, biomaterial properties. Biomimetic calcium phosphorus of the prepared nano fish bone and the nano eggshell remineralizing solution seem promising effect and low-cost remineralizing solution for human enamel. Biomimetic human resources deserve further research to be clinically useful. Thank you for your attention, and I am ready for any question, please, and I hope it was beneficial for you.
Thank you, Dr. Hoda, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Doctor, for your presence and presentation. Now let's move on to the next presentation from Dr. Anup Panda from University of Gujarat, India. Hello, Dr. Anup.
Thank you
Are you
so
ready
much.
with your presentation? Hello, Dr. Anup. Hello, Dr. Anup. Are you ready with your presentation? Well, hello, Dr. Anup. Hello, Dr. Anup. Hello, Dr. Anup. No, sorry, Dr. Anup, you are not audible yet, but your mic is on. I have made you as a presenter. Kindly check your screen sharing option once. The top right corner, you have settings button. Kindly choose your microphone settings over there, please. Dr. Anup, if possible, can you please use any other device or check your microphone? Hello, everyone. Let's wait few more minutes as there is a technical issue from Dr. Anup Sen.
Am I audible now? Hello? Hello?
Hello.
Yeah, am I audible now?
Yeah, you're audible. May I know for which
That's
device
wonderful. Yeah, yeah,
I should
please.
make you as a
Uh,
Okay, now I'm making you as a presenter. Kindly click on the screen button to share your screen, please. You can start your presentation.
yeah,
Make it as in a presentation mode and start your presentation.
1 minute, please. Now that you have bared so much of time, please.
Okay.
Okay, you have to bear with this. I think this is an old PC. Can I start
Okay,
now?
no problem. Oh, no problem. You can start your presentation.
Sorry for all that delay. You know, technology, I can blame
No
it to
worries.
that.
No worries. You can start your presentation.
I'm so sorry. Hello everyone, and so here we go. And my presentation, it's time to jump into a pool of new ideas. Perhaps you already know something of this work, but if not, then I am Dr. Anoop, a pediatric dentist from India, and my topic for today is rethinking conversational hypnosis, which is a great tool in pediatric dentistry, and probably we'll get to see how. Wouldn't it be fantastic if you could simply wave a magic wand at children to get them to do as you want them to? You will do exactly as I wish. Abracadabra. Sounds too good to be true? I can't give you a magic wand though, but can certainly show you how to put magic when working with children. The magic is you can change more things than you could ever dreamt of just through the power of your words. That's possible, my dear friends, and we call it as the conversational hypnosis. Hypnosis is a state of consciousness involving focused attention and reduced peripheral awareness, characterized by an enhanced capacity for response to suggestion. That's how American Psychological Association defines it. Dear friends, please take a moment to try this for me. I think it's going to be fun. Please take a deep breath in and then close your eyes and count to 5 in your head as you exhale. Then open your eyes and continue listening. Do that now. Okay, why did you do that? Because I told you to? Exactly. That, in its most basic and simplest form imaginable, was suggestion. So, in psychology, the definition of suggestion is the action of influencing a person to accept an idea or belief uncritically. So, if at its core, suggestion is as simple as that, then how much more simple will it be used to as a way of influencing children? So the art of influencing the child's mind in a normal conversation by selecting the use of correct words and language patterns is considered as conversational hypnosis. Yeah, it's a scientific and a systematic method to change thoughts, emotions, behavior in a completely unconscious way. So when you speak and communicate in a way that they not only listen and understand but respond to you in a positive manner, and that is influence, an influence to persuade them while carrying a normal conversation. So this linguistic art and science is accidentally practiced by all of us, and all of the time. So we generally do it often without realizing we are doing it. And we pediatric dentists use a form of hypnosis and suggestion throughout the working day that we generally call as the chair side mannerisms. Asking a young child to close his eyes, sit quietly, and imagine something internally is rarely successful. That what happens in a traditional one. Suggestions that ask a child to pretend to dream or imagine that you are dreaming are too cognitively complex. So the effective way of hypnosis is through words and patterns usually carried out in a conversation. So when you put these principles into practice, everything you do and say will enable you to, I could say, communicate with the child's subconscious mind. So, conversational hypnosis relies on your thoughts, words, body language, and tonality working together in harmony. So, friends, this presentation of mine is an honest attempt to bring application of conversational hypnosis in a very practical manner and a fun manner. And you would get to see the use of hypnotic communication skills and some pediatric hypnotic strategies to enable children to cooperate, and you could get to see the children working with you better. The history of conversational hypnosis primarily reflects the contributions of my guru, the late psychiatric genius Dr. Milton H. Erickson. He was the founder of American Society of Clinical Hypnosis. So let's see what exactly are the basic differences between a traditional hypnosis and a conversational hypnosis. To start with, we have something called as overt and covert. The traditional hypnosis is a description given to the sort of hypnosis that can occur when a person is aware they're going to get hypnotized. You get them to close their eyes, do some sort of hypnotic induction, and lead them to relax while focusing on your voice. Then you make some direct or indirect suggestions. Whereas in conversational hypnosis, we communicate with the subconscious without them getting to know. The problem with traditional one is that the language and behaviors are structured very differently from a conversation. However, it doesn't translate easily into a conversational format. It requires some imagination and a lot of practice to make this sort of structure sound anything like a conversation. Like as a conversation goes, the child finds it really boring. So, let's say, well, you are sitting here listening to my voice. It doesn't work out that way. The solution is to begin with the conversation and interact. Children can really spot a hidden agenda in a traditional way. They just know something is wrong, and the result is that uh, you can really lose their trust. You know, the second being purpose. Traditional approach is used for therapy, while conversational is used mainly for persuasion. So, hence, even if they are both effective, they cannot be used for the same occasion. The third being the faster. Another limitation of traditional would be the need for more time for dental consultation. Conversational hypnosis is generally carried out faster than traditional one because traditional session generally lasts between 15 minutes to an hour. When we call it a script, scripts do have success, and it makes sense to use them when you realize that subconscious mind has so much to do. A script provides a sense of ease and calm for the hypnotist in traditional way. The time you spend looking for and adapting scripts, or writing or rearranging or editing scripts in preparation for your patient is time taking. Of course, it's time taking. Standardized written scripts unfortunately promotes the idea that hypnosis is simply the act of reading words and suggestions from the right script. Such limited training also negates the importance of interacting creatively and flexibly with children, which is very important in pediatric dentistry. So scriptless hypnosis works, and it has its own magic when practiced. Trance is what the brain does naturally when it encounters something for the first time. Within that trance, there is openness to change, a readiness to see and experience the world differently. So, trance is a term used to describe an altered state of consciousness in which external realities become unimportant. We want the child to start screening the environment and having unhelpful thoughts race through their mind. So, it's important to recognize that all communication invites the receiver into a hypnotic trance. So, whenever we make a statement, the person hearing our statement cannot help but respond to those words and to the thoughts. They will connect some meaning to what we say, and at least for a moment, as they focus on that meaning, it puts them into a state, a hypnotic state of inward focus. So, when they focus on the meaning that they give to our statement for that moment, they enter trance. So trance is a word used to identify the conditions under which someone responds to hypnotic suggestions. Therefore, being able to identify a trance or the signs of trance, it can help you know when a hypnotic relationship has been established. So it gives you a green light to proceed. So how to spot someone who is in trance? So the child would exhibit the following changes. When you see dilated pupils, you know that you have more than their attention. You know, the pulse rate would slow down when you are talking to them. Changing breathing patterns, yeah, altered breathing, speed up or slow down, both are equally valid trance signals. You would get to see them, the relaxed facial expressions. Maybe the child would less blink but slightly unfocused. Probably they're paying close attention to what you're saying. And if you see them beginning to make some subconscious responses to what you are saying, that means they are in trance and in harmony with you. We generally call them as passive responses. And you might as well get to see some cessation in the movements or gestures, or else there might be a reduction in the swallow reflex. Now let's unpack what happens in hypnosis. I want to present to you a very powerful formula, a three-step model that, in fact, is one of the master keys for understanding any hypnotic process. The first being absorb and focus their attention. So you need to draw the child's attention from the external environment to the subconscious. While this may sound a little complex, but it's quite simple. Maintain an eye contact first with the child in a similar way that you would focus on a particular spot. This will eliminate distractions to help them focus and relax. Start a conversation to hold attention. This is a very easy thing to do. All you have to do is to ask them questions about their lives and talk about them. Use details of the conversation to steer in a hypnotic direction. The secret is to get them to talk about themselves and their interest. My technique generally consists of asking the child questions about an experience, and the more detailed the questions get, the more experience the child get into, which produces an altered state. This induction is basically a zero pressure, so it's a no pressure induction. Second being bypassing the critical factor. Critical factor is a part of your mind that tells you this is not possible, this cannot happen, Since the goal is to reach the subconscious, you need to bypass this critical factor and stop it from interfering. And you can do this in various ways, like by telling engaging stories, or using words that could elicit emotional response, or using power words that could trigger the subconscious, like imagine, or else remember the last time what happened. And the third being like achieving the first two steps will automatically pave the way to accomplish uh, the subconscious mind, reaching out to subconscious mind. So you might get to see the mind getting into the hypnotic state. So as you can imagine, the process is a very fluid one. It can happen in a matter of minutes or even seconds. And once you have uh, successfully engage them in a hypnotic state, you have the power to plant whatever ideas you choose in their subconscious. All of our interaction and communication with the world begins with our thoughts, and all our thoughts are represented to us by five main senses. I am sure: visual, auditory, kinesthetic, olfactory, and gustatory. And whatever the outside world is really like, we use our senses to explore and map it. Children use all of their senses to create their own reality, but mostly one uses a favorite sense more often than the others. Try to determine what is a child's dominant sensory channel. Do this uh, by listening to the words they use to describe experiences. So while in conversation, begin speaking to them using their favored sensory channel. Compare the words in each column out here to determine the dominant mode of communication. Child whose dominant mode is visual will tend to use words like look, see, bright, clear. So as the one with auditory would use, you could see that listen, hear, sound. And finally with kinesthetic mode, they would generally use the words like feel, touch, handle. So we are looking at representational system, which means the way that we represent the world, the way we think about the world, and the way we talk about the world. So when you are talking with someone and you are using the same representational patterns that they think in, they are relating to you tremendously and are extremely more open to your subconscious suggestions. So if you could communicate directly with the subconscious mind, you could communicate anything to anyone at any time, and the outcome would be exactly what you would aim for every single time. So talking within a different representational system is rather like talking a different language. Oh yes, we do agree that representational system is very unique, and might as well you could say that as unique as fingerprints. Trust is paramount if any relationship to exist, and that can only be created through rapport. So the magic of building rapport is the ability to hold someone's attention and create a sense of trust. Learning to build rapport at will is one of the most rewarding skills. It makes communication easy and effortless. Communication, we could say that it's an exchange of information. Yeah, it's getting your message across. So when you connect with them, they feel it too, and that's when they lower their defenses. Rapport is a term generally used to express the relationship of two or more people who are completely sync uh, on the same wavelength as each other. One way to establish rapport, something you have been doing anyway but without thinking about it, that is behavioral matching. That means what the other person is doing or something very similar. What all you can match. So rapport exists on a subconscious level, like the way I mentioned. This means if your subconscious mind notices another person demonstrating a similar gesture, facial expression, tone of voice, or even a shared opinion, your subconscious mind will automatically acknowledge a similarity and create a link. We all know people like people who are like them. So what all we can match, we could see that the body posture, the breathing rate, the voice, the language patterns, So definitely, we could say that building rapport is one of the foundations of effective influencing. Establishing rapport using mirroring and matching another person's body language and voice tonality. This creates generally a bridge between our world and theirs. To start with, the first, mirroring their gestures. So the important thing to remember is the word subtle out here. You don't want to appear to be mimicking the other person. The idea is to either match what they are doing and saying or mirror it. Mirroring refers to simultaneous copying of the behavior of another person, as if reflecting their movements back to them. The art says that when we are around alike people, we feel a sense of comfort and understanding. You must look at yourself as a mirror image of that person. Your gesture only has to be similar within about maybe 30 seconds for the subconscious to pick up. This sends the signal that you are like them and they would feel closer to you. So second being breathing with the child. Their breathing and the rhythm of their breath is another way in which you can get to their world. If you want to pace their breathing, pay attention to their breathing and breathe the way they do. So when you're matching the person's breath, it sends a subconscious signal that you are on the same wavelength. And another advantage to this is probably when you're speaking, it seems to their subconscious like they are the one who is saying what you are saying, because you are taking a breath at the same time in between words. So when you do this, it matches their internal dialogue, and they think that what you are saying is exactly what they are thinking in the first place. uh, could you see how informative this is? And it is simple, but it works. Trust me, it works. The third being of verbal breathing synchronization. This is also very interesting. Like you should pace your verbalizations, like the way you talk, to match when the child either inhales or exhales. Stay consistent. Begin by simply noticing your breath when not speaking. So you would get to see the length of inhale will definitely be as long as the exhale. So when speaking, we modify our breathing because we only speak when we exhale out. So therefore, inhales would be shorter than exhales. So when we pace our um, voice to the natural rhythm of our breathing, the attention of the listener is generally altered. This is the one of the most interesting slide. We generally say that eyes are a window to the soul, so we can see into people's souls through their eyes. Let me ask you, like, what is the color of your first bike? I'm sure everybody's eyes goes up and left. And in case if we have to visually construct something, like if I ask you, what would your house look like if it were painted violet with red circles? So you are constructing it visually, so your eyes just go up and right. And in case if you have to remember some sounds, so probably if I ask you, what does his voice sounds like when he was 10 years old? Your eyes generally go center to the left. And in case if you have to really construct some sound, like would your voice sound like how would your voice sound like in 20 years from now? Yeah, yeah. You could get to see your eyes going towards the right side. Like it's and for kinesthetic, like it's both emotional feeling and sensation. Like if I ask you, what does it feel like walking barefoot on the ice? So your eyes generally go down and right. And in case if you have an internal dialogue or else you are talking to yourself, you generally get to see your eyes down to the left side. Let me explain you this. There are two spheres of the brain. The right manages the more creative and the conscious side, and the left the analytical and the subconscious. So in any conversation, watch the child eyes. Are they looking to the right, accessing the conscious, or the left to the subconscious? If they are accessing to the subconscious, you can make a suggestion that they are not consciously aware of. It is easy to know if a child is thinking in pictures, like I have mentioned, sounds or feeling. And the idea is a superb one to understand how different child think, and would be an definitely an invaluable skill, you could say, to communicate better. Voice, the hypnotic voice, what we call, is a frequency of waves. Like voice is a frequency of waves. It's a movement, like it's a sound that our ears perceive. They are the phrases we pronounce while speaking. So a voice with variety contains a combination of a pitch, pace, pause, volume, a word emphasis. Like, let's try this out. You will open your mouth. If I say in a simple monotone, uh, you will open your mouth, like as if you're reading it from a to-do list. If I go take it as a rising tone, you will open your mouth. That becomes a question. A question is generally uncertainty, so even if spoken like a statement, it sounds uncertain. And if I take it downward tone, you will open your mouth now, it becomes an order or a command. Like how our mom used to say, you'll have to eat now. So when you want to make a suggestion but don't want to give it a strong impact, in that case you say it in a rising tone. Oh yes, humor when done well, with respect, definitely works with children. I hope you. Yeah, this is the most important of all. How do you generally induce a trance using the techniques? So during trance, a child's awareness is markedly decreased, resulting into high suggestibility. The child is less likely to question what he hears. Let's go with technique number one, like inducing a trance using pattern interruption. Covert hypnotic pattern interrupts are the, you could say, simplest ways to put someone into a very momentary trance state. Pattern interruption is generally an unexpected breaking technique in the conversation that will help us to change the state of the child or the course of conversation, you could say. So anytime that you interrupt a person's state of mind, they have to actually go inside into their thought process to figure out where they were when you interrupted them. That's where a sort of blank spot in the brain can be filled, and then you think about it, you understand that it's true. So a more covert hypnotic interrupt which you can use in everyday conversation is simply interrupting the person you want to hypnotize the sentence. So all of your I'll explain you how. Like, all of your sentences are formed in your mind, isn't it, before you actually speak them. So imagine that you are the individual talking. Okay, so you could think of a sentence right now, begin to say it, and if I were to interrupt you right in the middle of your sentence that you had already formed in your mind, your thoughts would go blank for a moment. It happens. Yes. So this blank space is full of opportunities for me to put anything I like. They're like, you really like me. Do you see how simple it is? Yes, it works, and you can use it for anyone. And we could have some dialogue stoppers, like, why are you agreeing with this when you know it's true? Or the less you try, the more you will agree. You will get to see many more conversational stoppers in my website, dranup.in. Please log into that. You will get to see more information on CHR as well. The technique number two is like inducing trance with overlap realities. This is an open loop, like constantly weaving a story in another, in the third, in the fourth, and so on. So a story inside a story inside a story. So this confusion makes the mind very, you could say, tired, and separates the speaker from the content of the speech. The consciousness is not able to understand these stories that don't have any relation with each other. Let's say, once upon a time there were three little wolves and a big bad pig, and then there was a wolf who cried, boy, boy. The neighbor's mother, cousin's brother, daughter heard. The boy was the fifth son of the fifth son, and the wee foxy woxy started chasing the little bunny rabbit. And when you're saying that, you can start with a slow hand pace, and you will open your mouth. While the mind tries to solve this puzzle, all of your hidden commands go to the subconscious. The third being a verbal confusion technique. The confusion technique is used to create confusion, so then things start to happen. And verbal confusion means like, the a behavior pattern. You could say that with game of words or information in a conversation, which creates confusion. So, and this definitely leads to an heightened suggestibility when you're working with child. Like Dr. Seuss says, if you cannot convince them, confuse them. I can take an example, like, I'm asking you to listen to what I'm saying, and you want to listen to what I'm saying to sit still. That chair is there, and that chair is there, and where is there is there, and if that chair isn't there and that chair isn't there, it hurts, and it might hurt a while longer. It will probably keep left and right until it stops. So what the child hears, it stops, because rest all were vague. So even a crying child, if you say this, if you remember it and say, you will get to see the child stops crying. A child who goes into hypnosis may experience reduced tension also, and even reduced tension related pain. Vagueness in language is an incredibly important influencing tool, and it permits the listener to create and personalize the meaning behind your words. Uh, the conscious mind tries to understand the vague and put everything on a logical order. You can use this principle to distract and make contact directly with subconscious. Oh, you have no idea about the purple giraffe. Do let me tell you about it. It's great. The purple giraffe came from the plastic bucket, but in no way similar to the jumping horse. Breathe from your nose. You could get to see things happening. But the simplest one is like this: give a simple fact, followed by an adverb, and then follow with the command. Like it's 11 in the morning, so obviously you sit still with your mouth wide open. It's a Tuesday afternoon, so obviously you all are enjoying the presentation. So those who control language control people's mind. So language is such a lovely thing, isn't it? The use of language plays a major role because we are treating children with words. I could say that words are power, words have power, and words could be your power. A simple choice of word can make the difference between someone accepting or denying your message. You can have a very beautiful thing to say, but say it in a wrong word, it's gone. Boom. So words can change worlds, and communication skill is a main part of the clinical activity in working with children. Moreover, not all techniques are equally effective in each children. This newly developed tool, once practiced, would build an agreement. You could get to see the shift the focus of attention, motivate and persuade the child during behavior guidance in pediatric dentistry. Putting it all together, I'm so sorry for all the slides. These are so well made, but since I have changed the PC, it's all coming improper. So sorry for all that. Putting it all together, get in a good state and meet them at their map of the world. So if you want to get someone into a good state, go there first yourself. If you want the child to feel relaxed and at ease, make sure you feel relaxed and at ease. The ability to guide children into different states is one of the most powerful skills for communication and change. Speak their language. We spoke about representational systems. So talking with a different representational system is rather like talking in a different language. Use your most powerful tool, that's your voice. So intonation is the rise and fall of pitch in a sentence, like the way we discussed. It's possible to express different meanings and emotions through intonation without changing a word you are saying. Children will more likely to do what you want them to do if the request is made with a descending pitch, because it opens the command module in the brain. uh, Establish rapport, like getting on the same wavelength. Sit like the child said, stand like they stand. If they speak slowly, slow down your rate of speech to match their. If they speak fast, pick up your rate of speech to match theirs. If they speak loudly, adjust your voice volume to match theirs. If they speak softly, you speak softly. You get the idea, don't you? The key principle is, we should know people like people who are like them, and we should know first connect and then direct. So one strategy is to speak with the same rate and tone. Time your rate of speech so that you only speak when the child is inhaling or exhaling, and adjust your body posture slowly and subtly, and you will get to see magic happening. The another one I could definitely stress, which I missed it out, like say what you do want, not what you don't want. Like let's say, how about I ask you not to think of a piece of chocolate cake? So what happens? What image comes to mind? Definitely a chocolate cake. Well, let me explain this why. It's because there are no pictures for negative words like don't, no, not, never. So our minds can only make pictures from the remaining words. If you want the child to do something, you need to flip your sentences around into positive terms, staying away from any negative words. So that's why it's important to ask the child to do exactly what you do want them to do, rather than telling them to stop doing something what you don't want them to do. Okay. And there are some power words, like the way I said, imagine, remember, pretend. And so these are very magical words, and it goes like indeed, you should say, like, these words, if spoken at the right time, in the right way, you could definitely have the results. They can change anybody's sense of thinking. As we end our story, we all know the best dentistry is a cooperative interaction. So with conversational hypnosis, the art of interacting with children is taken to a higher level, I could say. Conversational hypnosis is all about communication skills. Communication is all about the connection. So when you connect to the child, everything is possible. So the way in which we communicate to children is a matter of choice, isn't it? Our choice. Choosing how we communicate is something over which we have total control. With a bit of brain science, you can bring more calmness in your dental office. So as you reach the end, please know that I only had the scope to just scratch the surface. There is so much more to conversational hypnosis. Sure, there's a lot about conversational hypnosis that cannot be proven or measured in like double blind clinical trials. But again, we should know, like, stand-up comedy doesn't work under laboratory conditions either. Yet we all enjoy a good laugh. No matter what, you can take this stuff works in real world working with children. So conversational hypnosis is not about getting children to do things they don't want to do. It's about getting children to want to do things, the things that you want. These are some of my work, and that's me. And when I'm ending this, again, I would bid a big sorry on my behalf. And in case if somebody has questions, I would definitely love to reply them.
Thank you, Dr. Anup Kumar, for your presence and presentation. Does anyone having any queries?
Thank you so much.
I hope there are no queries. Once again, thank you, Dr. Anup, for your presence and presentation. Now let's move on to the next presentation from Dr. Andressa from Brazilian University Central Brazil. Hello, Dr. Andressa. Are you ready with your presentation?
Yes.
Okay, now I'm making you as a presenter. Kindly click on the screen button to share your screen, please.
Hi, my name is Andressa Santiago. It's a pleasure to make part of this event. I'll be presenting a case report of squamous cell carcinoma. Oral squamous cell of carcinoma is a common red and neck cancer. It has a higher prevalence in certain parts of the urine and is associated with a right motor rigidity and the associated risk factor, um, smoker and alcohol. The cause of squamous cell carcinoma is multifactorial, non-ethnological agent of factor carcinogen, RISB defined, or accepting but both extrinsic and intrinsic. Factory
Hello,
may
Dr.
be
Andressa. Sorry for the disturbance. Can you please make it your presentation in full screen mode, please?
Yes.
Can you please make it as a full screen mode, please?
Yes. I will be presenting a case report of squamous cell. Oral squamous cell of carcinoma is a common red and neck cancer. Its rates a rate prevalence in certain parts of the world and associated with a right mortality range and the associated risk factors were alcohol, smoking, and alcohol. The case of squamous cell is multifactorial, non-ethnological agents are factor carcinogen. Risk B defined accepted but both extrinsic and intrinsic factor may be H1. It's probably the be more the only factor required to produce this neoplasm. Co-carcinogens extrinsic factors include external agents such as smoker, alcohol, syphilis, and all four labs, vermelhos carcinomas, sunlight. The objective is to describe a case of squamous cell carcinoma affecting the edge of the tongue, classified as superficially invisible squamous cell and setting in raw myolecoderma, present as squamous smoker. Case report. Patients looking for dental clinic for discomforted DH for of the tongue, ancient and speaking when the intraoral examination was performed. A milky smooth, black and irregular contours were observed, removable wall was recommended through excisional biopsy, followed by suture. The sample was sent to histopathology, and the presence of superficially invisible squamous cell carcinoma was confirmed. The patient returned to the clinic for 7 days removal of the suture and with the diagnosis. Conformers referred to the red and neck surgery sector with total removal of the lesion was performed. Ravel according to report on the agent the agent of the lesion is still compromised. Treatment is a treatment um, Excisional biopsy was performed of complement removal of the pathology. HBR, anesthesia the lingual apex, incision of the tongue, um, of the tongue as a trend. Excisional biopsy was performed of complement removal of the pathology. HBR, anesthesia the lingual apex, incision of the tongue, within a true of sutural trend. To perform tongue transition and anesthesia in the region of the pathology. Subsequent and incisional biopsy of the lingual was performed with marginal when 315 blade and region. In conclusion, the end of incision was simple state 5 was sutural trend, removal of the lingual, apprehension trend, and post-op operative prescription and orientation. Histopathological report smoking cell carcinoma os conformity. After 7 days, when the suture was removed, the diagnosis was confirmed. We referred the patient to the neck surgery sector and followed for 10 days. Conclusion: it's observed the lesion of squamous cell carcinoma is one of the most frequently oral neoplasms. Therefore, it's necessary to pay attention to the clinical signs and histopathologic exams become when the lesions are diagnosed and less advanced stage of the survivor can reach up to it persistent. Therefore, it's important to study and analyze tongue squamous cell carcinoma to better understand its prognostic factor, reduce morbidity, and the direction is treatment. Thank you for the opportunity. Goodbye.
Thank you, Dr. Anderson, for your presence and presentation. Does anyone having any queries?
Thank you. Yes. Dr. Camila. Bye bye.
Marilla, hello, Dr. Marilla, are you ready with your presentation?
Repeat, please.
Hello, Marilla, are you ready with your presentation? I have made you as a presenter. Kindly click on the screen button to share your screen, please. Hello, Dr. Marilla.
Hi, sorry for demo.
Yes, your screen is shared. Can you please open your PPT and
Can I start?
yeah, you can start your presentation.
Okay, thank you. Uh, Hi, good morning. My name is Mirella Cunha. I speak for its case of lingual frenectomy for the treatment of ankylosing and intertrilateral review. My name is Mirella Caroline Coenda Cruz. I am student at the Federal University of Pernambuco, and today I will present a scientific paper entitled Frenectomy: Efficacy of Lingual Frenectomy for the Treatment of Ankylosing based on integrative literature. Let's go. Ankylosing conceptualization is an anomaly oral of congeniality, which has the characteristic of lingual frenulum intersect close tooth apex, often toggle, making breastfeeding and swallowing of babies poor. Such anomaly is hereditary, with genetic factors of autosomal dominant genesis relating to the X chromosomes. The objective of the pesquisa to reproach the efficacy of lingual frenectomy as a treatment for ankylosing. Its messages is listed in integrative literature, review, boutique, blogged the respective descriptors, ankyloglossia, lingual break, and pediatric dentistry. In the chat on the DEX platform, and the keywords were searched on the online platform Cielo, PubMed, and Virtual Health Library, which 15 actors being found, drug development operator, and however only 22 articles were used because they fit inclusion criteria, being complete and free, internet access, being Portuguese and Spanish, as well as be from the last 10 years. The result, lingual frenectomy in Dern, is responsible of restoring trunk mobility, and the surgical procedure can be performed by dental surgeon. The scientific literature suggests that surgical intervention be performed in newborn during first 6 months of life and cases of recurrence. It should represent the burden, a rapid success, a grounded tongue mobile, or is treatment with speech. Repeats can also be indicated in addition to surgical procedure. uh, a lingual frenectomy is efficient of the treatment of ankyloglossia because it is produced recognized by the old literature on the reaffirmed by current one. Multidisciplinary follow-up is also necessary, aiming at the treatment is intended. Thank you for a question.
Thank you, Dr. Merrill, for your presence and presentation. Does anyone having any queries?
Thank you for you. Bye bye.
Bye. I hope there are no queries. Now let's move on to the next presentation from Dr. Melina Catherine from Federal University of Pernambuco from Brazil. Hello, Dr. Melina. Are you ready with your presentation? Hello, Dr. Melina. Yes, Dr. Melina, now I'm made here as a presenter. Kindly click on the screen button to share your screen, please.
Hello, good morning.
Good morning, I have made you as a presenter. Kindly click on the screen button to share your screen, please.
Yes, thank you. My name is Milena
Your screen
Catherine.
is not shared at Dr. Melina. Can you
Yes,
please share your screen?
repeat, please.
Your screen is not shared yet. We are unable to view your presentation. Can you please share your screen?
Yeah.
In the
Okay.
GoToMeetings app, click on the share button, which is the third icon in the bottom center.
Okay, I will solve. One moment. Okay?
Yes, your screen is shared. Please open your PowerPoint presentation and start your presentation.
Okay. Apparatus 3. I go start. Can I start? Hello? Hello?
Yes, you can start. You
Okay.
can start.
Uh, the advantages of teleodontology for contagion reduction during pandemics. Hi, my name is Milena Catherine Cohen da Cruz, student of the Federal University of Pernambuco. Today, I will present scientific paper intituled The Adventures of the Teleodontology for Contagion Reduction During Pandemics. The regulation of teleodontology in Brazil, established by resolution of the Federal Council Dentistry number 226/2020. The use of this tool is aimed at extracting reading information with the intention of promoting reach service relating to demands that present a need to overcome geographic barriers. Uh, the objectives to analyze the evidence brought by the use of teledentistry during pandemics. Methods. The study is an integrative literature review which relied on the respective database for its preparation. Virtual reading library PubMed and Cielo using the transcriptors telestrip, pandemic, and digital history. 56 articles redefined. One, one river after applying the inclusion and exclusion criteria. Only 40 were that number. Timely is lips of the last 10 years. Articles in English and Portuguese and Spanish and talk about tele teledentistry in contrast applied to the region of contagion. exclusion criteria, hair, layers, and opinions. Results: 25 of the articles used bring a historical context about the telestorage reproaching in emergency drug telemedicine, which was delivered from telehealth and previously worked from the doctor to doctor method. Uh, for fear of the underexed literature mention the benefits reduction in the cost related to displacement, considered both patients of professionals in health centers. This couple of generous reflects also in the reduction of track density, innovation in service, and the opening of doors for application in cases of pandemics and epidemics are also consideration. I mean, under fracture threat is a possible reduction in the transmission of certain diseases. 20% of the workers report difficulty implementing this tool. Teledentistry is capable of bringing positive results when used in pandemic contexts with the intention of reducing contagion. Even so, more informed students on the topic are needed. And it was very important for health odontology. Thank you. Any questions? Hello? Hi? Hello, peoples?
Hello, Dr. Melina.
Hello?
Have you completed the presentation? Has your screen was unshared?
What?
Your presentation is completed.
Yes.
We are unable to view this. Okay, thank you for your presentation. Does anyone having any queries?
Oh, have
I
enough.
hope
Thank you.
the I hope there are no queries. Thank you once again for your presence and presentation, Dr. Melina. Now let's move on to the
Bye.
next presentation from Dr. Victor De Bruno Souza from Brazilian University Center, Brazil. Hello, Dr. Victor. Are you ready with your presentation?
Yes, I am.
Yes, now I'm making you as a presenter. Kindly click on the screen button to make your screen. To share your
Okay.
screen, please.
Can you see that?
Yeah, your screen is shared. Can you make it as a full screen mode and start your presentation, please?
And now, can you see that?
Yeah, perfect. You can start.
So, good afternoon. My name is Victor. I'm a student from Brazilian University Center. Okay. Um, and in this congress, I will address the topic of guided tissue regeneration as a method of treating furcation lesions caused by periodontal disease. Okay. That's the preoperative clinical appearance. This technique, based on research by specialists, is the field such as Folden Jr. and Dominguez et al. Aims to regenerate structure damaged by periodontal disease through the application of grafts such as biogate and xenogenic bovine bones. In this congress is a case report, okay? And during my presentation, I will explain the basic principles of this technique, the results obtained by it, using according to a surgical case which was reported, and my own conclusions about this step. So, in this treatment, I just put here step by step for you all can see all of the things were done. And you can see here the assembled surgical table with all the instruments and all of the things that we used, almost all the things, okay? That's the initial x-ray and you can see the preoperative clinical, the preoperative clinical. Can you see that? Oh, hello? Hello?
Yes, Dr. Victor.
Can you see the slide? It just
Yeah,
was
it is
stopping
visible.
here.
Your screen is visible. Yeah.
Okay, so here is the incision made and tissue removed with a Goldman Fox number 2 curette, and you can see in this doping the BOOs and blood being mixed. The BOOs and blood were mixed for inversion unification area, and you can see in this photo here. The next step was remove bone tissue to reestablish the biological space using BOOs and blood from the patient. You can see the preparative clinical aspect as I was showed, but here with the clinical mirror, there is a mirror view. That's the texture of the mixture from BOS and blood and cutting out the membrane, the biogate. Okay, positioning the membrane. So, guided tissue regeneration is a surgical technique for treatment of lesions caused by periodontal disease. This technique is aimed to regenerate the damaged periodontal structures of the bifurcation or trifurcation of multi-rooted teeth. We use biogate grafts or xenogenic bovine bone. A surgical case was reported of a patient with leukoderma developing a grade 2 furcation lesion. After applying the previously mentioned guided tissue regeneration, it was possible to observe the revitalization of the surgical area. You can see the completed suture, and after that, the manipulation of surgical cement. That's the piercing after 7 days of the procedure, and you can also see the radiography after 7 days. You can see all the structures how are after this procedure. Okay. In addition, it was possible to perceive a more advanced level of bone filling radiographically and due to consistent radiography present in the furcation region. After the manipulation of the cement, you can see the adductor surgical cement, and there is the radiography after 14 days. You can see how are fast this regeneration with that method. And this is the adaptation of a new surgical cement after the end of the 14 days. Okay. The results after 14 days was possible to release the revitalization of the surgical area and radiographically noticed, as I said. So therefore, it can be concluded that the guided tissue regeneration technique was this case a high-performance surgical technique to treat lesions caused by periodontal disease. It is important to ask for discussion of new treatment strategies and new research aims to a better understanding this topic and optimizing this technique. Okay, the method I use in this article was a surgical case report of a gait tissue regeneration in a leukoderma female patient, like a technique to treat a case of grade 2 frication lesion. So that's all. Thank you. Hello.
Thank you, Dr. Victor, for your presence and presentation. Does anyone having any queries?
Yes, for Dr. Camila and Dr. Elvira Barros, who helped me with this job. Thank you.
I hope there are no queries. Once again, thank you, Doctor, for your presence and presentation.
Excuse me, I couldn't understand what you said.
Thank you for your presence and presentation, Dr. Victor.
Thank you too for calling me. Bye bye.
Thank you. The next presentation is from Dr. Raul Medina from University International de Castellón, Spain. As he is not available, we have a video presentation from his end. So we'll be sharing the video presentation from our end. Or if you have any queries, you can reach him via his email, which is presented in the last slide. Okay, the next presentation is from Dr. Yashko Darko from UIC College of Dentistry, USA. Dr. Yashko, are you ready with the presentation? Dr. Yashko, are you ready with your presentation?
Yes, I am.
Yes, thank you. Now I'm making you as a presenter. Kindly click on the screen button to share your screen, please.
Can okay, just a second.
I have made you as a presenter.
Okay, so it asked me to quit and reopen again.
Yeah.
Hello, can you see my screen
Not yet.
now?
Yeah, your screen is shared now. Can you make it as a full screen mode and start your presentation, please?
Okay, how about now?
Yeah, it's perfect. You can start.
Okay, thank you. Um, all right, good morning, good afternoon, everyone. Um, my name is Yasker Darko. I'm a clinical assistant professor at UIC College of Dentistry. I'm honored today to speak to you about my research. My research topic was published just in January in at the Journal of Operative Dentistry. It was part of my residency program, the thesis that I conducted at UAB School of Dentistry before joining UIC. So the content of this presentation will be the introduction, reviewing the literature review and statement of problem, objectives and hypotheses, materials, methods, statistical analysis and results. Then we will discuss the findings and then the limitation of my study and the conclusions drawn from my study. So research evidence has changed in the last decades from metal ceramic into metal-free old ceramic due to the superior optical properties, high static demands, and increased cost of precious metals. So this is a study conducted by Christensen et al. In 2014. It shows the shift, the dramatic shift from the metal uh, dependent dentistry, mainly in PFM, represented in 65% in 2008 and to 78% in 2013. The gold restorations declined as well. So what are ceramics? Ceramics are compounds of one or more metals with a non-metallic element, usually oxygen. This could be silica, which is silicon and oxygen alumina, which is represent aluminum and oxygen, or zirconia, which is composed of zirconium and oxygen, according to the prosthodontics glossary term. So dental ceramics by microstructure could be classified into predominantly glass as a feldspathics. We have particle filled glass like lithium disilicate or lithium silicate reinforced glass ceramics. And we have the polycrystalline ceramics family, which is the alumina and zirconia. So this is another study run by Mikaji et al. In 2016. It shows that lithium disilicate was the leading ceramic restorations in 2016, followed by layered zirconia, lucite reinforced PFM, and monolithic zirconia at a 5%. For posterior restorations, however, monolithic zirconia was the leading option for dentists as a permanent restoration. So zirconia is the metal oxide of zirconium. It's a polycrystalline matrix. It's known as high strength material and fracture toughness. Um, Popular with the name that the white steel. So it can exhibit transformation toughening, and also it's largely replaced the alumina-based ceramics because of the last feature, which is the transformation toughening. So the zirconia could be in present in three polymorphic material in nature: a monoclinic phase, usually at room temperature, the tetragonal at 2370 degrees Celsius, or cubic at 2680 degrees Celsius. So the metal oxides, such as yttria, could be added to the zirconia to stabilize the zirconia at any one of those three phases. So the transformation toughening that we talked about is due to data change from the tetragonal into the monoclinic. So when this change happens, the tetragonal crystals will change into the monoclinic, which is they're 4 to 5% larger in size. So this increase in volume will add compression at that expanding crack. This could happen in restoration, and it will stop the crack from propagation. And this is known as a transformation toughening of zirconia. So the zirconia is on the right picture. You can see the powder, how it's produced, and then it heated up to form the required tetragonal or the cubic phase, and then yttria could be added to stabilize the crystals during cooling and to maintain it at the formed phase. So after that, the zirconia powder after cooling could be pressed, and this is what is known as the green state. So that green state is usually sintered through the sintering machines, and then could be milled, or we have the white state material that could be milled and then sintered. And this sintering process will produce 20 to 30% contraction. So the evolution of zirconia, we know that zirconia, since its introduction in dentistry, has evolved. It was a high strength opaque material in the past, and deuteria added and the alumina also reduced in order to improve the optical properties of the zirconia. So also with this change, the physical and mechanical properties of each material has changed dramatically. So the first generation of zirconia is known with the 3-mole yttria, such as the lava frame. It contains also the 0.25% of alumina oxides that prevent the water corrosions at the grain boundaries. The microstructure was mainly tetragonal, and it's also an isotropic, meaning that it has different shapes for those crystals, and that's why we have the opacity, because of the amount of light that is being scattered due to the physical properties of that type of zirconia. So these one used mostly for copying and frameworks. In case of static restorations, it required a feldspathic lining at the top. We had a high chipping rate early on with the layered zirconia restorations, and that's why there were many attempts to make the zirconia more translucent to be used as a monolithic restorations. So changes happened on the level of the yttria content. So the yttria changed from 3 to 4% mole percent, such as we have the lava plus and the Katana SCML. The alumina oxides were also reduced from 0.25 into 0.05%. So the microstructures stayed largely tetragonal. The strength and transformation toughening preserved. Translucency improved slightly, but still inferior to the glass ceramics. A further modification was necessary to improve the translucency, and here where the 5Y mole yttria percent zirconia was introduced. So this one contains mainly or roughly 50% tetragonal and 50% cubic. The cubic phase is an isotropic, has the same shape, allow the light to pass easily, and it it provided the material the translucency that is needed. So the translucency has been significantly improved. However, strength has been reduced in this type of zirconia because the cubic is weaker than the tetragonal, and it has around 50% cubic, 50% tetragonal content in the material. So the transformation toughening is reduced. Some research, they say it doesn't transform anymore. So the literature review and the statement of problem that since the introduction of the acid etching of enamel and dentin, we know that the restorative density advanced from direct bonding into bonding in direct ceramic restorations, conservative partial coverage restorations, compromised preparation or ceramic restoration thickness, resin bonded fixed partial denture ceramics, and full coverage restorations benefit from bonding to two structure by using dual cured resin cements. So the problem with zirconia is that it's an inert and very low reactive material. It has a polycrystalline matrix, which is it makes it impossible to apply the glass-based ceramic bonding protocol for bonding zirconia by using just a traditional hydrofluoric acid etching to create the surface roughness or using the saline application, which we know that can bond chemically to the glass matrix of the silica-based ceramics. So the most accepted protocol for bonding zirconia combines mechanical and chemical surface pretreatment prior to adhesive resin cement application. So the mechanical surface pretreatment is usually achieved by aluminum oxide particle abrasion to clean the ceramic surface, increase surface energy, and improve the wettability of the intact zirconia surface. So this step is followed by the chemical pretreatment, which is the 10 mdb primer or 10 mdb containing resin cement for chemical bonding. So we have this three steps that's known as clean, prime, and bond, or the APC, which is air particle abrasion, prime application, and composite resin cementation. So this is how the mechanism of 10 MDB works. The phosphate end usually bond to the zirconia, and we have the methacrylate, which can bond to the resin cement. So these are another graphs by my professor, shows the difference in the dental ceramics that we use today, going from far left, which is the glass. We have the crystals in the glass. We still have a glass to etch to and to infiltrate the resin to bond mechanically, and then the saline to bond chemically. On the far right, you can see the solid centered zirconia, which doesn't have any glass at all that we could etch to bond to. So the non-etchable ceramics on the right side, and the etched representing the blue material as a glass that could be removed. So this is what sandblast does on a specimen of zirconia. We can see the S-centered, just like we have the lines of the machine, and we have the glass beads. Some type of particles that produce very little surface damage compared to the alumina, which reduced significant roughness, which is needed for bonding. So this back to the statement of the problem. So we know that the mechanical surface treatment by alumina is the perfect method to bonding to zirconia. Since zirconia has changed from strong zirconia into more translucent but a weaker zirconia, so we have McLaren and his group reported that when new high cubic containing the third generation of zirconia is abraded by aluminum particles for mechanical surface treatment, the strength is reduced. The mechanical roughening is necessary to achieve the durable bond, but it can also impair the strength of the high cubic containing zirconia. So therefore, the optimal pressure and the particle for mechanical surface pretreatment have to be determined to achieve an optimal surface for the durable bonding without impairing the strength of zirconia restorations. So for that reason, we conducted this study to investigate the effects of the particle type, the pressure, and on shear bond strength and biaxial flexural strength of the first, second, and the third generation of zirconia. So as the objectives to measure the surface treatment by alumina particles at three pressures, 15, 30, 45 psi on shear bond strengths of lava frame, lava blast, and lava static zirconia. And we also tested the glass beads in this regards, and we measured the biaxial flexural strength of the alumina of the lava zirconia treated by the alumina particles at 3 different pressure, and also the biaxial fluctual strength after the glass beads particle abrasion. So the null hypothesis was that there will be no difference on shear bond strength of Panavia SA cement to surface treated lava frame, lava plus, lava static zirconia when alumina particle abrasion applied at different pressure. 15, 30, and 45 psi. There will be no difference on shear bond strength of Panavia SA cement to surface treated lava frame, lava plus, and lava static zirconia when glass beads particles abrasion applied at different pressure, and there will be no difference on the biaxial fluctual strength of surface treated lava frame, lava plus, and lava static zirconia when alumina particle abrasion applied at different pressure. Say 15, 30, and 45. And the last hypothesis was there will be no difference in the biaxial fluctual strength of surface treated lava frame plus and lava static zirconia when glass bead particles abrasion apply. So these are the 3 materials represented in the study by lava frame from 3M company. We have the lava frame and lava plus in the middle and lava static. So the cement that is used is Panavia SA cement. The cement contains the 10 mgb monomer that could bond to the zirconia. The particles that is used, we have the alumina, which is by Cobra, and we have the glass beads. We have the SEM representing each material. We can see on the alumina side, it's more aggressive particles and more condensed compared to the glass beads, which shows it just um, less dense and less aggressive type of particles. So we also ran particle size analysis because most of the manufacturers manufacture present their particles based on the size, the mean size of those particles. And it's known for specific numbers like 50, 100, 110. So what we did, we sent sample to the 3M company in order to run a particle size analysis, and we found a different result actually than what is usually presented by the companies. So for the alumina, the mean particle size was 82.84 microns, and we have the range from 47.56 microns to 122.9 microns. For the glass beads, the mean particle size was 72.67 microns with a range of particle sizes from 57 to 89.26 microns. So this is the particle size analysis graphs. This is for the glass beads. So the 420 specimens of lava was distributed as a 140 for each. We have the 14 groups, 5 for shear bond strengths, 7 for biaxial fluctual strengths. So this is the table shows the group distribution. So we have the control which received no surface treatments, the test group for alumina at 15 psi, at 30 psi and at 45 psi, similar to the glass beads, were distributed at 15 psi, 30 psi, and 45 psi. So the shear bond strength was conducted using this 3M sandblaster device. We had distance is controlled, the timing was controlled, and this is the last picture showing that how to use that gauge, the 10 millimeter distance during particle abrasion. So after that, the specimens were cleaned in ultrasonic cleaner, completely dried with air. We measured the curing tip in order to verify the output for the curing lights to cure the specimens. So we used a clear tube to fill the cement on the specimens, and the specimens was cured from the top, right, and left. The total curing time was 30 seconds. This is the complete specimens after bonding. The specimens is kept in water for 24 hours, and the specimens was placed for testing after that using the instrument machine, and this is the shows the blade coming at the specimen, and this is the broken or the specimen after loading to failure. For the biaxial flexural strengths, the same specimens received the same treatment. We tested the strengths as well. using the Baxter Flusher strength test. So after bringing the specimens according to the experimental group, the thickness of each specimen was measured by a digital caliper, and specimens was placed in a fixture mounted on the instron. The untreated non-abraded surface of the specimen is placed toward the piston, and the specimen subjected to failure by applying an increased load at a crosshead speed of 1 millimeter per minute using electromechanical testing machine, instron, and the fractional load data were collected and submitted to the following equation to obtain the final results in MPa. So this is it shows the instron machine, the specimen in the picture ready for testing. So the statistical analysis, a two-way ANOVA analysis, was used to analyze the difference between surface treatments material and their interaction. The variables were particle type and pressure, and Toki test was used to determine intergroup differences. P-values were set as 0.5. 0.05. So the significant differences were seen between surface treatments, materials, and their interaction. So materials in each column with a different italic ladder are statistically significant. So the null hypothesis was partially rejected. So this is the graph shows the shear bond strengths for the three material: lava frame, which is the strongest zirconia, and then lava plus, which is the 3Y zirconia with reduced alumina, and then lava static, which is has the 5Y zirconia. If we can see on the bars for the shear bond strength, so the first one is the control. The second one is the 15 psi. I'm reading for the lava frame. So the third one is the 30 psi alumina, and the fourth column is the 45 psi, and then we have the three bars for the glass bead. So we can see the more the pressure, the higher the bond, and this is statistically significant for the 45 psi, which has the A ladder, compared to the 15 and 30 psi, which has a B ladder. So for the lava blast, we have B as a control, and then we have the A ladder for the three pressures. When we use the alumina, it's statistically significant compared to the control or the glass beads treated group. For the lava static zirconia, we have the A is the highest bond strength that was achieved at the 15 psi pressure, followed by the 30 psi and the 45 psi surface treated lava static zirconia, and this difference is statistically significant. For the glass beads, it didn't produce the strength that is higher than the control group, and there is no statistical significance between the glass beads treated group and the control group, which received no surface treatments. So when we compare the strength we have with the lava frame, after alumina abrasion, we have the strength is almost 1600 megapascal. With the 45 psi group, it actually surpassed the 1600 MPa, followed by the lava blast. The lava blast is the surface treated zirconia stayed below the 1600 MPa. For the lava static zirconia, however, the strength declined. So the first bar, it represented control, which is around 650 MPa. The second bar with the 15 psi alumina surface treated group is below the 600, slightly below the 600. The more the pressure, the weaker the specimens produced. So for the surface treatments, we can also see we run the SEM testing to see the amount or the quality of the surface treatments after abrasion. We can see starting with the the first one, which is the lava frame, and then we have the different pressures or different particles used in the second row and the third row. The higher the pressure, the more roughness that we can see on those SEM samples. So I'll skip the discussion, and this is another study was conducted by my mentor, McLaren et al. They presented similar data that with the high cubic containing zirconia or the 5Y zirconia, when we apply higher pressure for surface treatment, the strength usually declined. Um, So step ahead the discussion. So the limitations of this study was that commercially available sandblasting units varies greatly in regards to the scope of delivery, meaning that device nozzle sizes. In this study, we used the 3M sandblaster unit with a tip diameter of 3 millimeter with a 1 millimeter aperture. The sandblasting units with similar characteristics should attain similar results. The duration of particle abrading might need to be adjusted in case of the, let's say, the clinical scenario. And we know that surface of the restoration is usually larger, more complex than just a small disc. So the conclusion of this study, so within the limitation of the present study, regardless of the applied pressure, glass beads particle abrasion provided no benefits as a mechanical surface treatment prior to bonding zirconia. Also, it adversely affected the strength of the lava static when the applied pressure was 30 or 45 psi. Mechanical surface treatment achieved by aluminum particle abrasion produced a significantly better combination of bond strengths while maintaining the biaxial flexural strength of the lava frame, lava blast, and lava static zirconia. The recommended pressure based on this study for surface treatment of lava frame, lava blast, and lava static zirconia, three and reduced alumina and the 5Y zirconia for best combination of bonding and strengths are 45 psi, 30 psi, and 15 psi respectively. Thank you very much, and I'm open to any questions the audience might have.
Thank you, Dr. Yesko, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Yesko, for your presence and presentation. Now we'll continue with the individual presentation from Dr. Raul Medina.
Thank you for having me.
Thank you. Thank you, Dr. Yesko.
First of all, thanks to Coalesce Research Group for the invitation to present at this Congress, a great Congress about clinical dentistry and oral health. I'm going to talk about the tensions through dynamic occlusal forces in implant support processes according to the restorative criteria. One of the biggest challenges in dentistry is to restore the stage of oral health and be able to maintain it over the years. And we have solved this problem. An important challenges arise. Maintaining the situation over the years. Patients are not free from, in the future, they may suffer alterations in their health, such as gingivitis or diabetes at a systemic level. Biological problems such as periimplantitis or mechanical problems such as fractures or of the rehabilitation materials. When we have excess of load in implant in a state of optimal gingival health doesn't affect the restoration of the implant, but in situations of gingival inflammation and excess of load and implant prosthetic restoration can cause peri-implant bone loss and the possible loss of the implant and the restoration. Therefore, it's important to know the forces that affect the stomatognathing system and that affect implant rehabilitation and their effects. Okay, in our mouth, we have forces can affect restoration on implants. Static loads like biting when making physical force or clenching or eccentric bruxism are forces dynamics. We can do difference between static loads, biting, and dynamical loads, eccentric bruxism, and chilling. Here there are a video that represent the difference between static loads and dynamic loads. This is a static load done like biting, okay? And this is a dynamic load done chewing. It's very different which forces can affect the implants and their rehabilitation in our mouth. But we don't know if the dynamic forces or the impact has different transfers of the forces than the static loads. When our rehabilitation materials is subjected to a load, it generates the same stress and doesn't vary from the material of different thickness. To know the real value of this force, a dynamic impact analysis must be carried. There are different study models to know which are the forces that can affect our rehabilitation. One of these is the digital image correlation. This is a block that has points, black points, and when we apply force, the morphology of the blocks vary, and we have the possibility to know which is this variability of the resin. Another option is the photoelastic resin. This resin varies the color depending on the force transmitted of the law. Other are the extensometric gauges. We can use extensometric gauges in vivo studies. And finally, other option is the finite element analysis of 2D or 3D. Situations in which there, in absence of cortical bone in contact with the implant, there are patients that have a peri-implant disease or areas of previous bone regeneration, immediate implants and subcortical implants. In all of these cases, there are the absence of the cortical bone around the implant. The objectives are to know which are the mechanical properties of the restored materials and analyze under dynamical force shows different stress transmission to the bone. Knowing these capacity properties of the restorative materials helps now to choose the better restorative materials for our treatments. We use a similar method that I exposed before, but changing an important thing. We conducted a study of stress dynamical forces, dynamical, not statical force, in implant supported prosthesis crown according to the restorative materials using a finite element 3D but dynamic. This is the novel technique, dynamic 3D finite element. Conducting these studies, we published these two articles in a materials journal. These two different articles that we can expose here. First, we create an integrated model with the prosthesis and the bone section of the mandibular. This model was converted to the EGS, and with the software ANSYS Workbench, we created a finite element model, with 96,116 nodes. The distance between the nodes was less than 0.2 millimeters. Here we have the node in the under the static coverage of the crown. Here we have the node in the abdomen. Here we have the node in the cortical bone, and here in the trabecular bone. To conduct this study, we have the different physico-mechanical properties of the rehabilitation materials. We use 6 different crowns, one created by carbon fiber composite and covered with composite bioxide. Another one is a metal ceramic crown created by chrome cobalt alloy and a ceramic coverage of PMK 95. Another was metal composite crown created by coral chrome alloy and composite BioX5. Another one is a metal crown, a full metal crown about cobalt chrome alloy. Other one is fiber composite crown with a coverage of ceramic. And the last one was a crown of pig and composite. It's a pig Optima core and composite BioX5 from coverage, steady coverage. Here we have all the characteristics of these materials, the young modulus and Poisson ratio and density of everyone. Finally, we simulate the impact between the model and the plate with a distance of 0.01 millimeter. The conditions are similar in all the materials, anisotropic materials and homogeneous. The osteointegration of the implant is considered all of the body of the implant osteointegrated. The simulations it's in a time of 0.4 milliseconds, and we have 53 different moments to validate with an interval of 7.55 microseconds. This is a simulation of the impact between all the system from abutment, implant, bone to the plate. Okay, here we have the mathematical forms about the energy cinetic energy, that it depends of the mass of all the system and the velocity. And the potential energy, it depends of the stress state of deformation, and the volume and differential volume. How we can different properties in density of the materials, and we need to have all the crowns, all the possibilities, the same mass to compare the impact. We added a different mass if we need, but for every different crowns studied. And when we compare the possibility of the model without the cortical, we need to add the mass of the cortical. This is the boundary conditions. A distance to the plate is 0.01 millimeter, and the velocity of the simulation was 1.25 meters by second, and the acceleration of the mouth in opening was 2.5 meters per second. But we suppose the same acceleration with the biting or closing than the opening. Here we have the results, and we can see a very difference between crowns. We have rigid structures like the crown of metal or metal ceramic. Very big differences between crowns with the coverage of fiber composite. All the crowns covered by composite has less stress in the crown node and in the abdomen and in the bone. Here we have the results, and the crown has less, 70% less between metal and metal composite crown. In the abdomen, we have 44% less stress between metal and fiber composite, and in the cortical bone we have a 50% less between metal and metal composite. Here we have the graphs in the case of the with and without cortical bone. In the cases that we don't have cortical bone, like an regeneration zones or peri-implant zones, implant zones without cortical bone, and we have a irregular oscillations. But in the same case, there are more transferences of the stress with materials, with crowns. We have materials more rigid. This is the results in the table, and we have in the big composite we have less than 60% of the difference between with cortical and without cortical. Okay, and in metal ceramic there are 55% of difference between the impacts. To compare these results with another articles, we look for an article that Gracis and Nichols that compare using gauges compare the impact the translation of the stress under the material, and they looks at 44% less stress in the metal composite than in the metal ceramic. Now, this is in our study, and in the study of the Brazils, looks for 43.3% between composite and metal. It's a very similar results than our studies. In the Magne study, they compared using an in vitro study using the peiometer and the energy loss coefficients. In the crown of an implant with a composite core and the composite revelation, the one with the highest energy loss coefficient, and the crown with the zirconia and ceramic core, the restoration the least. Therefore, it is observed that the high values of loss coefficient correspond to the material that present greater energy absorption. In vitro passive study, by dropping a weight on the samples, they observed significant difference between crowns and with ceramic veneers. Percentage variation ranging from 10% to 30% in vivo found no significant differences between the use of ceramic coated crowns rigid and resin coated crowns less rigid. Otherwise, in the Menini and Conserva study, they find a difference between Empress 2 and Sigmund that 61% of the absorption in the stress. This study used a robot with a lot of sensor gauges sensor, and they represent in the robot, they represent the mastication's movements. In our study, we found a 44% of difference between the stress of metal ceramic and metal composite. Vallis and Guidus et al. Looks a reduction in the impact force of more than 6.75%. An impact was not made, but a study of dynamic force was used in which the applied force was constantly increased until reaching 1000 newtons. The same forces are used and they give the same tension because it is not an impact, it's an increment of the forces. Taking into account the limitation of comparison of the results obtained through different methodologies and evaluation of different materials, the stress reduction effect on material with less rigidity is verified. Static coating material is the one that most influences impact social. The rays which lower stresses on the ground surface and the peri-implant. We have found in the literature research about 3D finite element and dynamical analysis that use impact forces. And there are the first studies of the using this system and in the rehabilitation material on it. We can evaluate the tension generated and transferred to the different levels in the implant restoration, the crown, the abdomen, the bone in the cortical and in the trabecular one. And this is very difficult to have in other studies that nor are finite element analysis with other methods than gauges or TIG. It's very or photoelastic resin. It's very difficult to conduct. And we think that the best method to conduct is the 3D finite element analysis with a dynamical. We are acquiring another studies in the same line of the research, varying new materials like zirconia, like lithium desiccate, and with different design like the bridges or like all mouth structures. And at the same time, we are doing a study using a matching design for us and produced for us, for ourselves, to compare the different material in the end of the rehabilitation of the implant with different sensors. Finally, the use of less rigid materials reduces the stress transmitted by an implant force to the implant supported crown, abdomen, and bone, cortical and trabecular. The absence of cortical bone increases considerably tensions generated in the trabecular bone. Thanks for your attention. See you soon.
Well, that was a video presentation from Dr. Raul Medina. Now, the next presentation is from Dr. Shimaju Christine from UNIFHEA, Brazil. Hello, Dr. Shimaju. Are you ready with the presentation?
Hello, how are you? Nice to see you. Nice to see you, not to see you. Nice to be here today. Thank you so
I'm
much.
good. I hope you are doing well. Now, are you ready with the presentation?
Yes.
Okay, now I'm making you as a presenter. Can you click on the screen button to share your screen, please? Your screen is shared. Can you please open your PPT and start your presentation, please?
You see something?
Yeah, your screen is shared. Please open your PPT.
I will try to do like this. Can you see?
But your PPT is not clear.
It's not clear.
It's
Oh
not
my
clear.
God. Just a moment.
Can can you log in GoToMeetings app from your laptop?
It's better now.
No, actually, your screen is visible in a very small tab from your screen.
Because my
If possible,
laptop
can
is
you
not.
send your PPT to the program manager? She'll be presenting from our end so that you can give. She'll showing the PPT from our end, her end. Then you can give the presentation.
Okay, I will try to do this. Just a moment.
Okay. Please share that PPT to the program manager for in WhatsApp.
Mhm. I can't do this.
No, sorry, your screen is not clear. Is a the phone app is not supporting. The camera is very the camera option is very showing in a small tab.
I like this. If I you telling about the PRP, what do you think? Hello?
Can you share the can you
Can
share
I
your
continue?
PPT to the program manager, please? Because it's a camera, but you're using showing your presentation from your camera, which we are unable to see. It is very short tab.
Yeah, but that's what I can do now because my MacBook is not so nice.
If you have your PPT in your phone, can you please open the PPT from your phone if possible? I have sent you an image in your WhatsApp. Can you see that how your PPT is looking? Hello, hello, doctor.
Yes.
Can you join from your MacBook if possible to
In the MacBook, it's not working. The meeting, the go to is not open. Just in my iPhone. In my conference,
Can you
it's
transfer
inside
that
my MacBook.
PPT to your iPhone and start showing from your system from your phone to us? Or please send an email of that PPT to our program manager. I have sent you a message in WhatsApp. That's the way your screen is able to view for us, which your PPT is not visible clearly to us. It's
Yes.
very it's showing in very a small tab.
Mm-hmm.
I have just sent you a message in WhatsApp. You can check.
Okay.
Mm.
Dental researchers. Cat.
Hello, doctor. Have sent you the presentation.
I'm sending to your email.
Okay.
Did you got it? I sent it by mail. Did you receive my mail?
We have received your presentation. We'll be showing your presentation from our end. You can see the presentation and you can continue to give the presentation.
Okay. Is it possible to see the presentation?
We'll be showing your presentation from our end. Then you can give the talk by seeing the presentation from Dr. Catherine. We'll be showing your PPT from the presentation.
Can I begin? Can I begin? Can I start?
Hello, Dr. Christian. We are unable to open your PowerPoint presentation. Can you
Okay.
please resend it again? Then there's an error in that file.
Would you like that I send you again the email?
Can you send it again? Can you please, if possible,
Okay.
can you send it in a WhatsApp?
Okay. Okay. Here we go. Can I start?
Hello, you can start with your presentation, but before to change the next slide, can you just intimate us with the next? Okay.
Okay. Okay. Today we're talking about PRP, plated rich plasma, to autofacial biostimulation. So I'm from Brazil. I'm a dentist, and can you change the slide, please? Yes, my biography. I'm from Brazil. I'm a dentist, postgraduate in human anatomy at the University of São Paulo, master degree in biomechanical engineering, PhD of materials engineering, professor in postgraduate in Unifatea in Brazil, international speaker, and this is my one. Can you change the slide, please? Okay, here you are. PRP is a procedure based on injection in a amount of blood with a lot of platelets to fill expression lines and soften wrinkles. Despite being widely used for aesthetic purposes, it's also possible to use PRP method in case of dental implants and in a general surgeries. The next, please. Okay, the next, please. Okay, how can you do this? Materials and methods. The professional takes about 20 ml of patient's blood, places it in an anticoagulant tube with calcium chloride, and puts the mixture in a centrifuge for 6 or 7 minutes. The role of calcium chloride is to stimulate the separation of platelets from the rest of the collected blood. After this preparation, the solution is placed in a syringe to be applied to the desired location. The session takes around 30 minutes. The next, please. Advantage. PRP is 3-5 times more potent than unhandled plasma due to the high concentration of growth factors that help stimulate the production of new cells and proteins such as collagen. The, man, the, man, the maintenance of the PRP method depends on the degree of expression marks and aging of the patient, which may require reapplication in 6 months. This aesthetic procedure for the face is suitable for people over 30 years old because it's precisely during this age that the face begins to show the first signs of aging. This is we can see in this picture before and after treatment. An old man about 50 years old. The next, please. Recommendations after procedure. After performing the PRP procedure, the patient should avoid sun, physical exercise for 24 hours, and other aesthetic procedures in the face region for 24 hours too. Do not use makeup or any kind of cream in the face for the next 24 hours. The first signs of results may appear 7 days after application of PRP, platelet rich plasma. Next, please. Contraindications. Very young people, because they don't need any kind of aesthetic procedure. Patients who are anticoagulant medication, who are using anticoagulant medications. Patients who have blood disorders that compromise the success of the treatment. Autoimmune diseases like lupus. Sky lesions where the procedure will be performed, such as herpes. The next, please. Conclusions. The facial rejuvenation method with PRP is effective and safe because it's a procedure compatible compatible with the organism, easy to apply, and with excellent results. We can see in these pictures the excellent results we can take. Next, please. That's all. Thanks for your attention. I'm sorry because I'm not so good in the internet, but it's okay. Thank you so much.
Thank you, Dr. Shimaju, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Doctor, for your presentation.
Thank you so much.
Now, by this, we come to an end of Day 2 webinar. I would like to thank all the attendees and participants of today's virtual conference, and we'll be glad if you could join us in next in-person conference, which is scheduled in this year, November, in Dubai, and the dates will be informed to you by mail. We will be very happy if you could share your opinion and feedback with us. Thank you.